Yes, this is another low-rent Friday version of the podcast, so just listen on up. Welcome, folks, to The Dim Nurse, with me, your host, Blue. Ladies and gentlemen, time is the greatest asset that we all have, so thank you very much for giving me some of yours as we dive into this episode of the show. Once again, this Friday episode, not quite coming to you on a Friday for one very good reason. It's the holiday. Alright, fine. I did not manage my time very well and did not record the podcast on Friday or before Friday, so I was not able to release it on a Friday. That is the unadulterated truth to why this episode is coming to you today, Monday. That said, I think that there's some endearing quality about that. How many other podcasts out there promise you a release schedule and then never adhere to it? In my defense, all the Tuesday episodes were released on Tuesday without fail. There is something about Friday episodes that are a struggle. Mostly because I've been working my face off. But more recently, just my time management skills have gone to hell. I don't know why that is. That said, I've got some new and exciting technology that if I can master, I think will let me record anywhere. And that's going to be important. One of the biggest barriers is that I spend many hours of my week closeted inside the hospital in a windowless, ventilationless office and ICU. And so when I'm off, especially when the weather is nice, which here it often is, I want to be outside and doing whatever it is I want to do or can do. And I absolutely love recording the podcast, so I say, all right, I'm just going to record it at night. And that's fine. But the problem is, I get late or things get late or I'm running behind and then I record the podcast and then just recording it isn't quite enough for any of you unfamiliar with the process, which I really was. You gotta upload it to this and that and this. You gotta type this and that and this, and then you gotta have it go to here and there and wherever so that people can actually hear it. So there's several minutes, hours even, if you're a little bit of a newbie like me, of work, even after you record it, which assumes that you can speak properly, which can be a struggle for me, that you don't have 7,000 things going off in the background, which, for those of you who have listened so far, know that happens all the time. Yeah, so, it's a struggle, but I think now I have a gizmo that plugs into my phone that, from what I understand, lets me record on the phone, send it to this software that I use to record normally, and then from there, upload to, everything that it needs to upload to get out to you, the listener. Super excited about that. I'm going to try recording an episode from the beach. See how that goes. I'll be super excited if that goes down without a hitch. But whatever. I also think that there's, like I said, I think there's a little bit of an endearing quality. How many, surprises. Oh, God. That's terrible. The podcast is not that serious, folks. It's not meant to be that serious. And I think that adds a little bit of charm. If I promise you something on a Friday and it comes to you anytime between Friday and Monday, how many other podcasts can say that? Maybe that'll be the signature. The Phantom Friday episodes. The fake Friday episodes, the forever not released on Friday episodes, some kind of episodes that may or may not come to you on a Friday, in or around Friday, 1 or 2 days around Friday. This episode is very much going to be the Friday, I don't even know, the Friday FYI episode, which, fair warning, it's a little bit of a rant. Let me just tell you that Friday, I was at work, of course, story of my life, and I got no less than 30 FYI pages. Pages. First, it's lost on me why in 2020 I need a pager. Lost on me. It's also lost on me, one of the reasons I think that you need a pager in this, or in some, let's say some hospitals, is because cell phone service is shit. So it's also lost on me why in 2020 cell phone service in hospitals is still shit. I don't know. Lots of unanswered questions here, folks. So in any case, I got a pager. Okay, fine. It's very archaic. It is what it is. I got a call so often from a landline, which, yeah, we have those, of course. So often from a landline because, my cell phone doesn't have any service. Okay. So then some genius thought, well, maybe the way to get around that is to have also a cell phone that through some kind of witchcraft actually has service in the hospital. That's not actually true. It has pretty much the same amount of cell phone reception that my own phone has. Okay, fine. So now we have the pager, the cell phone, and then my own cell phone. And then depending on whatever somebody might want from me, whatever time of day it might be, or who the person trying to get in touch with me is, one of those three or more of those accoutrements may go off at any given time. Alright, so I got all that shit attached to me throughout the day or throughout the night. Okay, I can get past that. I can make my peace with that. I can accept that. But, okay, alright. When the pages come, these FYI pages come, they do have the potential to drive you to the brink. And, now one day, maybe, if I get this podcast off the ground and able to actually do it with some rigor and success, I may do one also for providers, and I will cover this piece on how to hopefully preserve your sanity from these pages, these pestilential pages, but also doing my piece, because at some point we'll talk about on this podcast contacting the provider. So I'm going to work at it from both angles. Telling the nurses when to harass the provider and how, and then telling the providers how to prevent being harassed. But anyways, FYI pages, one of my biggest pet peeves. So I got an FYI. Your patient's potassium is 3.9. 3.9. For those of you new to the business that have no idea what potassium is, you should leave the business right now, and shame on whatever nursing school you came from, because what the hell did they teach you? But for the purposes of today, and most days, an acceptable potassium makes no difference, 3.5 to 4.5. And for all of you nerds out there who are going to be like, oh, well, depending on what's wrong with them, they may need another potassium that's a little bit higher. And yeah. Whatever. That is true in select situations. For today, that's why I say, for today, 3.5 to 4.5 is fine. And so when somebody pages me to say, FYI, your patient's potassium is 3.9, I have to wonder why they would send me that page. Is it because they don't understand what normal potassium is? Is it because there's some kind of concern that they have that the potassium is 3.9? Why? Why are you paging me with this information? What am I supposed to do with this information? And quite apart from that, 99% of the time that I get these pages, the patient already has standing orders, previously written orders, protocols, such that the nurse can take free rein and give potassium for potassium that falls in whatever range, and then you can give whatever amount of potassium. It's already there! So I ask again, what is the point of this page? Alright, so I'll deal with that. Then I get an FYI. Your patient's hemoglobin is 6.9. For those of you new to the business who have no idea what hemoglobin is, shame on whatever nursing school you came from. But if you're doing any kind of prudent medicine, if your providers are practicing any kind of current, modern, conservative, evidence-based medicine, most of the time you do not need to transfuse somebody until their hemoglobin is below 7. And for you nerds out there who say either, oh, well, what if they were 11 and then they bled down to 6.9 or they bled down to 7? Aren't you still concerned that they're bleeding? Or for the other person who says, oh, well, 6.9 is less than 7. Let's deal with the second version of that first. If you are the kind of person that says, oh, the cutoff is 7, and I have a 6.9, oh, no. You need to take some kind of drug that relaxes you and blurs the lines of your reality a little bit. Okay? Let's be honest. 6.9 versus 7 is lab margin of error. It is essentially 7. No one is going to die with a hemoglobin of 6.9 when you wanted it to be 7. That is absolutely the case. For the other person who bled from 11 to 7 or from 11 to 6.9, I never, ever, ever, ever get pages about that. Ever. I get a page about a 6.9 that is completely immaterial. They may have had a 6.5 before that. They may have had a 7 before that. But it is absolutely within the realm of stability and far away from the realm of concern. I repeat, I never get a page for a concerning lab value like that, where it was 11, it's now 7. It's typically the reverse, where I will be poaching labs, which I do quite often, I might add, because I used to think it was absolutely disgraceful for the physician or the provider to tell me what my patient's labs were when I was a nurse. But now, strangely, as a provider, I still have that same view. And so I feel that I should know the lab values of these patients before their nurse. Let me just tell you, in the reality, when you have 10, 12, 14 critical care patients, you may not be able to do that. And you have to accept that, because it's much harder to be on top of 14 patients' labs in the moment that they result versus the 1 or 2 patients that you may have as a nurse. I'm slowly accepting this as the years go by. Let's gloss over that. But it's usually me saying, oh, hey, guess what? Your patient's hemoglobin is 6. It was 12. There's some kind of disconnect happening there. So I get an FYI. Okay. Your patient's hemoglobin is 6.9. And then I literally was in the bathroom at the time of this page. And I'm not camping out in the bathroom, folks. It's a very short process. Let's be real. In the time it took me to get out of the bathroom and walk to the sink, which is 3 feet away from the bathroom, it's a strange bathroom, I get another page. FYI, the patient's hemoglobin is 6.9. Please advise. As if that 5 minutes, they were so concerned that the patient was going to croak that they had to page me again with another FYI and then a request. Can you please help me? Okay. If you are that concerned, first of all, if you are that concerned, you should have a different kind of page than FYI. If you're concerned, so concerned, that this patient is not long for this world because of the hemoglobin of 6.9, you need to quantify that a little bit. So, say, hey, this patient's hemoglobin 6.9 was 15. Blood pressure, poor. Skin color, poor. Everything else, poor. Please advise. Okay, fine. I will not just advise you, I will physically appear in 1 second at the bedside. But this is not the case. It's always very FYI, misdirected rubbish, nonsense, shit. What else did I get an FYI about? Oh, I got an FYI. My restraints are expiring in 8 hours. 8 hours. Now, at the time of this notification, I was not even going to be working when 8 hours arrived. Now, I totally understand that if you are an astute, good, focused, and attentive nurse, that you are going to try to tuck in all those loose ends and annoying nuances, whatever, before the other shift comes. And that is the approach you should always have. In this case, it is night shift. This Friday in question was night shift, and it's 4 a.m. Nurses, I'm going to tell you, if you are just at 4 a.m. deciding what it is you may need for your orders for the future, or for PRNs, or for whatever the case may be, what the fuck were you doing for the last 9 hours of your shift? From 7 to 4, that's 9 hours. What were you doing? Why do you just now realize that you have an order that's expiring? Huh? So, lots of FYIs. This is just tip of the iceberg. There's FYI. The patient had a 5-beat run of VTAC. Oh, no. Okay, folks. I'm just going to say, even in patients, because I spent a lot of my life with these patients, even in patients who have an ill heart, not the kind of ill hearts that, people who don't take care of cardiac patients go, oh my God, their heart's so bad, their EF is 30%. I'm talking about the actual, real, sick cardiac patients whose EF is was less than or equal to 5%, their ejection fraction 5%, huge amount of ischemic disease, only alive at this time because of 1, 2, 3, or more pressors, or inotropes. Even they, of course they do. They have many runs of VT, sometimes a minute, 2 minutes, 30 beats, 40 beats, whatever. And even that is almost immaterial. Yes, in the grand scheme of things, in that specific situation, if you have an increased burden, you may get concerned that things are happening. But in the average Joe critical care patient who has a 5-beat, a 10-beat, a 15-beat run of VTAC, who in God's name cares? It doesn't matter. Nothing is going to be terribly wrong. And of course, you'll get an FYI. Patient had a run of however many beats of VTAC. And depending on the nurse, you'll be like, oh, I'm sending off all the labs on Earth to investigate this terrible turn of events. Or you'll get the other kind of nurse who'll be like, do you want me to send off every lab in the known universe to test this terrible turn of events? So it just depends on the flavor of the nurse in the moment. You don't have to do that. You don't have to do that. You do not need to do that. If your patient has an impressively low electrolyte, they should have some other ECG telemetry changes or more than just a 5-beat innocent run of VTAC, which anybody on Earth from birth to death can have with no drama. So, no, I don't think that you need to spend all the money and rush to check all the electrolytes on Earth. especially if somebody was paying attention to them earlier and replaced them earlier. And if you kind of know how much replacement they got, if you really feel strongly about it, you can give them a little bit more empirically. Empirically, this is called clinical medicine, not I need to spend the money because I don't know how to do medicine kind of medicine. So, FYI, and FYI, bludgeoned with FYIs. I only really ever think that a page or a call or a text is merited in a situation that deserves immediate intervention from a provider to avoid immediate death. For example, come now, the patient's in cardiac arrest. Great. I will be there. Or come now, the patient is 1 minute from cardiac arrest. Great. I will be there. Or come now, the patient's arm is missing. Great. I will be there. Or come now, the patient's shot. Great. On my way. But, electrolytes, mediocre hemoglobins, a useless amount of ectopy on the monitor, that probably the patient had no clue about, the nurse had no clue about, somebody up in the bowels of the hospital or down in the bowels of the hospital who's a monitor tech staring incessantly at these screens of telemetry saw it and they're like, oh, something happened in the day. Let me call. And then they get on the phone with the nurse and they sell it. Oh my God, your patient. Check on your patient. How is your patient? They just had 5 beats of VTAC. And depending on the nurse at the other end of that call, who may not be able to filter that into a category that is benign, especially if they're a newbie, they'll be like, oh my God, oh my God, oh my God. And they'll run frantically and bring half the unit with them and be like, my patient had 5 beats of VTAC. It's unnecessary. All right. Ladies and gentlemen, I'm going away now. This was the Friday rant version, the low rent rant version of our show. A little bit of a detour from the typical, but I am going away now. Thank you very much for listening. You've been a very attentive audience to work towards. Take care. And if you're going to work, if you're going to school, whatever it is you're doing, if you're paging somebody, think twice. Hopefully, you're a little less